Welcome to the Psychedelics Anonymous webinar series on psychedelics. Today, I have the honor and pleasure of welcoming our guest speaker today, Dr. Ben Sessa. Dr. Sessa has specialist training as a child and adolescent psychiatrist and is interested in the developmental trajectory from child maltreatment to adult mental health disorders, including adult addictions. Dr. Sessa's joint interests in psychotherapy, pharmacology, and trauma have led him towards researching the subject of drug-assisted psychotherapy using psychedelic adjuncts. In the last 15 years, he has been part of scientific and clinical studies administering LSD, psilocybin, ketamine, MDMA, and DMT to patients and volunteers. He is the author of psychedelic medical exploration books, including the Psychedelic Renaissance and To Fathom Hell or Soar Angelic. He has recently completed research with Imperial College London, exploring the world's first MDMA-assisted therapy trial for the treatment of alcohol dependence syndrome. And with that, we welcome you.
Hello. Hi, Burton. Hi, Adam. Good to see you. Thank you very much for having me here.
It's a pleasure. We're going to have some time today to dive in and really talk about your area of expertise. And we'll start with MDMA and then switch gears and discuss ketamine later on. So with that, let's zoom out and invite you to explain the pharmacology of MDMA and how it affects the brain and body.
Okay, so MDMA, 3,4-methylene-dioxymethamphetamine, is a synthetic psychedelic compound. Strictly speaking, it's what we call an entactogen rather than a classic psychedelic. It works across a number of different systems in the brain. I would say it's the perfect drug for trauma-focused psychotherapy. Indeed, if you were going to invent a drug that ticks all the boxes for trauma-focused psychotherapy, you'd come up with MDMA. And its pharmacological profile is reflected in its benefits as an agent for psychotherapy. So it has an effect in the serotonin 5-HT1A and 1B receptors with increased activity there. That accounts for the positive felt mood, the euphoria, the reduction in depression and anxiety. That's a very positive effect. It allows a patient to feel good and feel warm feelings of containment and security and empathy through those effects, the 5-HT1A and 1B receptors. It has a mild effect at the 5-HT2A receptors, which is where the classic psychedelics like psilocybin and LSD work, but much more mild than them. You don't get this ego dissolution effect that you get with the classic psychedelics, but you do get a sort of increased ability to see things from a new angle in a way, but in a much more mild way. Then it has a very paradoxical effect. There's a stimulatory effect via dopamine and norepinephrine receptors. That's good because that sort of speeds the patient up and motivates them to engage in therapy. Paradoxically, at the same time, it's slowing you down via the alpha-1, 2 receptors, which takes the edge off the hypervigilance that comes with painful trauma recall. So anybody who's taken MDMA would be aware of that strange feeling of being both speeded up and slowed down at the same time. And that puts you into what we call the optimal arousal zone for psychotherapy. So you're enhanced to take part in therapy, but you're not overwhelmed by the amphetamine effect. And then it has a hormonal effect via oxytocin. And as you know, oxytocin is the hormone secreted from the brains of breastfeeding mothers that engenders a sense of bonding and connectivity. So all of these things add up together to create this very unique pharmacological profile whereby MDMA turns off the fear response at the level of the amygdala, which is the limbic system in the brain. When that allows you to focus on difficult, repressed, usually avoidant memories that you wouldn't want to go to. So in a way for trauma, it's perfect. I think of it as like wearing a life jacket or a life vest to go into battle with your trauma. It's still difficult to work on these difficult traumatic memories, but with MDMA on board, you can do it. So that's its effects on the brain. It sort of all adds up to this wonderful agent to enhance psychotherapy on trauma. In terms of the body, More so than the other psychedelics, like the classic psychedelics, which are virtually inert physically. You know, LSD, psilocybin does virtually nothing to your body at all. MDMA does have a slightly higher toll on the body. It does raise your blood pressure and your temperature and your heart rate. Transiently, it goes up for about 40 minutes, plateaus for a few hours, and then comes back down. So you do need to monitor those things a little bit. But it's a very well-tolerated drug, and its pharmacology is uniquely set up for trauma-focused therapy.
So with that, can you explain the protocols and procedures that are involved in a typical psychedelic-assisted therapy session?
Yeah, so, I mean, I often lump together, you know, three very disparate compounds, ketamine, psilocybin, MDMA, because in the clinical setting, their similarities are greater than their differences. That's the way I would put it. They're all different, ketamine, psilocybin, MDMA, and anyone who's taken all of those at different points would know that they feel very different subjectively. But in the clinical setting, when you're using them together with guided psychotherapy, they're much more similar than they are different. They all have clinical benefits. Now, a typical psychedelic-assisted therapy protocol, whether it's MDMA, psilocybin, ketamine, DMT, LSD, whatever, some of the standard parts of it are that there are both non-drug sessions and drug sessions. And that's really important. It's much more than just taking the drug. So, for example, a typical course may be 8, 10, 12 weeks, and you would take the MDMA on 2 or 3 occasions, interspersed with non-drug sessions. And those non-drug sessions are so important, and often those are missed out. So you'd start with several weeks of preparation sessions without the drug, getting to know the therapist, building up trust between you, developing a bit of an agenda for where you want to go with the therapy. You would then have a guided drug session in which the patient usually would lie on a bed or couch with eye shades and headphones and very much be within the experience. Not a great deal of talk therapy goes on during the drug sessions, more so with MDMA compared to other compounds, but the patient's encouraged to just be with the drug experience for the drug guided sessions. Then crucially, you would have a next day integration session. So they'd come back to the clinic the next day, and that's where you do the bulk of the talk therapy work. The drug's worn off, they've had a sleep, but all of the memories are still there. And then there may be another couple of weeks off, then another drug session, and again, you repeat that. So usually 2 or 3 sessions with the MDMA over the course of 10 or 12 weeks.
Thank you for that. And what do you say to those who may have preconceived notions or biases influenced by the drug war as it pertains to hearing about MDMA and having a negative connotation and hearing horror stories about what happened in the 70s and 80s?
Well, it's very, very frustrating as a scientist that we are working alongside poor drug policy, which is unscientific, unpoliceable, unethical, dangerous, creates the mafia, feeds crime, causes social destruction, and kills people. It's not the drugs that are doing this. It's the prohibitionist principles of poor drug policy. And so it's a good question, Burton, because it's so frustrating as a scientist that we have to be up against that kind of negative narrative. So, for example, especially as a doctor, you know, the government doesn't interfere with how cardiologists do their job or orthopedic surgeons. They just take the advice of the experts and set up policies accordingly. But what's so frustrating about the drug war is that, you know, drugs are pharmacological agents. These are medical scientific products, and the government should be listening to the experts. And the drug policies are not in line with the actual realities of the safety or benefits of the drugs. So it's a really good question, because that's one of the additional pressures in this field that we have to deal with, not just the clinical issues, but having to deal with lousy drug policies from governments that don't listen to scientific experts. And the result is, as you rightly say, the stigma for the patients. So I guess what I would say is, look, don't make your inferences about the safety or potential benefits of these drugs based on what you read in the tabloids and what the government tells you about drug policy, because they're simply wrong. They're the wrong policies. And the result is this is an impediment or barrier to people accessing services. So it's very frustrating as a doctor that these erroneous policies result in reduced access to services and patients not getting the treatment that they deserve.
That's a great answer. And a natural follow-up that would follow would be to ask, what are the current legal and regulatory frameworks surrounding the use of MDMA in research and clinical contexts?
Yeah, so apart from what's just recently happened in Australia, which I'm sure we'll get on to talk about, so far all over the world, MDMA is a Schedule 1 banned substance. It's not a medicine with a capital M. It's what we call a research chemical. It's not been approved in any countries as a treatment, as a medicine with a capital M. So you can only use MDMA legally. I mean, if you can use it recreationally, or you can go to underground therapists, but you can only receive it legally on a treatment a research protocol, not a treatment protocol, which massively restricts its use because it's expensive to do research, and the whole concept of funding and participants versus patients is different from when you can use it as a treatment. So far, it's Schedule 1 banned substance all over the world. Now, the timeline for that changing, there's a group called the Multidisciplinary Association for Psychedelic Studies, MAPS, based in the States. They're really spearheading the regulatory changes for MDMA. Every time I speak to Rick Doblin, the director of MAPS, about when MDMA is likely to be licensed, every time I speak to him, he adds another 2 to 5 years and another $10 to $20 million. So it keeps getting pushed back and back. The current understanding is by the end of 2024, MDMA should be licensed as a treatment for PTSD, initially in the States, hopefully in Europe at the same time. So yeah, that's what we're looking at for MDMA, the end of next year. MAPS have finished what they call phase 3 studies, which are the final developmental stage. They're submitting the data to the FDA as we speak, and hopefully, fingers crossed, it'll be available throughout the world to treat PTSD at the end of next year. Now, Australia, is this a good time to mention this point? So in terms of regulatory, so very much out of the blue and quite unexpectedly, the Australian government have just made MDMA and psilocybin legal medicines as of the 1st of July this year. So in answer to your question, it was going to be the end of 2024, unless you happen to be in Australia, in which case, in a couple of months' time, MDMA therapy will be available as a treatment, not as a research protocol, but as a treatment. So that's a tremendous step forward.
And with your background and over a decade and a half at Awaken, pursuing research with MDMA, I understand you're now going to be having a presence in Australia as a physician who can offer this as a treatment. Wondering if you could just speak a little bit about how that is going to be different, what you're anticipating in that move.
Yeah. So Awaken Life Sciences was a biotech company that I co-founded about 2 years ago. And for me, it was very much the pinnacle of my career because I'd spent 15 years in the field, working in academia, working towards this. And it was always my goal to run the UK's first clinical psychedelic study, which we did with MDMA, and then also open the UK or Europe's first psychedelic medicine center, which we did with Awaken. So after doing that and working there with ketamine over the last 2 years, I've now resigned from that position to go to Australia. It came out of the blue for me, this offer to go to Australia. They asked me to run the teaching program and to set up teaching sessions and retreats and education sessions for doctors, therapists, clinical psychologists, nurses, pharmacists. So we're going to be running a series of training sessions, both face-to-face and over the Zoom, to educate doctors on how to write protocols to submit to ethics on using MDMA and psilocybin therapies. And because these are treatment protocols, not research protocols, they're a bit easier to write. You don't have to have as many measures. You have to collect some basic incoming data and exit data and safety data. But I think the truth is, none of us quite know how it's going to work. We're sort of making it up as we go along. We don't know how the government's going to react, but they're very favorable, which is great. So we'll have to see how it goes over the next 6 months. I think it'll be a good 6 months before anyone's actually treating anyone with these compounds, because they're going to need the training and they need to set up the infrastructure. But it's a fantastic opportunity, which I couldn't say no to, which is why I decided to leave Awaken and spend time in Australia over the next couple of years.
And through these teachings and educational pursuits, what sorts of knowledge do you share when it pertains to factors like dosage, purity, and discussing the setting and how that impacts the effects and risks of using MDMA?
Yeah, so obviously, we have years and years of clinical MDMA research under our belts, and various different protocols have been worked through and tweaked and changed to settle on where we are now with MDMA for PTSD. And it's a 12-week course with 3 sessions of MDMA, like I described earlier, interspersed with non-drug sessions, those vital prep sessions, the post-drug integration sessions. The dose is usually around about 120 milligrams, followed by a second booster dose of half that, 60 milligrams, after 2 hours. So that gives you a full sort of 4 to 6 hours on the MDMA experience. So that would be at each session, and you do those sessions 3 times over the course of the 12 weeks. So 120 milligrams plus 60 milligrams is 180 milligrams, which I think if people are wondering, what does that feel like compared to perhaps recreational ecstasy? Trust me, it's a pretty good dose. It's a good dose. It's a proper threshold dose. You will certainly feel the effects of that. We're not talking microdosing at all. So each session is a powerful session. In terms of purity, it's interesting whenever I hear sort of friends talking about, oh, I had some really good acid the other day or some good ecstasy. It's like, as a pharmacologist and using these clinically, we don't talk about good acid or bad acid or good MDMA or bad. It's just MDMA, 100% MDMA. Well, 99.98% pure MDMA. It has to be. It's a medicine. Just like you don't go to the pharmacy and get some good aspirin or some bad aspirin. It's just aspirin. So it's just MDMA. It's pure MDMA. By far the biggest impurity is the gelatin capsule. So the dosage is pretty set. It varies a little bit between, say, 80 and 120 milligrams, depending on the protocol. And you do that 3 times over the course of the 12 weeks.
Understood. Thank you for that. In your
you asked about set and setting as well, didn't you? Sorry, Burton.
Yeah, if you could, please.
Yeah, so I mean, when it comes, this is general rule for psychedelics in general, that we talk about these concepts of set and setting. Set refers to the mental mindset. So that's what you bring to the session. And this is why those preparation sessions are so important, that a person feels educated and confident and secure and safe. So you'll talk about the drug, how it works, what to expect. You have a trusting, bonding relationship between the patient and the therapist in the weeks before they take the first session. And so that's all, and it applies more to classic psychedelics like LSD and psilocybin. If you go into a trip thinking, oh my God, this is dangerous, I'm going to go mad, I'm going to go crazy, I'm going to have an awful time, then you will have an awful time. If you go into it with, this is safe and I know what I'm doing and I feel secure and I've got my friends around me and I've got an agenda, then you're more likely to get a positive effect. So that mental mindset is essential. Setting refers to the physical environment, or indeed the social or political environment in which you take the drug. So with psychedelics, you want to have plenty of time, you want to turn off your phone, you want it to be a warm, gentle, relaxed, peaceful place. You want to make sure you haven't got anything to do other than to focus entirely on the session. And again, this comes down to the skill of the therapist in providing this sense of containment for the drug session to take place.
Thank you very much for that. Something that you said in your prior reply that I'm wondering your particular thoughts on. You had said, what does it feel like? And I'm curious what your take is on whether or not you believe these therapists and providers who are going to be offering MDMA as medicine should have experienced a psychedelic trip or dose within their own life prior to offering it to others?
Yeah, really good question. And this comes up a lot. And the question of, should therapists have experiential training with the compound? My answer to this is ideally, yes. But it's not as essential as being a good therapist. This is my opinion. So, if you can, I think the most important thing is being already a good, established, experienced clinician, a person who's used to working with people with depression and anxiety and PTSD and trauma and child abuse, and you're already trained in those modalities. You understand basic concepts of clinician care, like consent and confidentiality and safeguarding. All of those things are more important, in my opinion, than just psychedelic experience. So I get a lot of people that contact me. They say, hey, Ben, I want to be a psychedelic therapist. And I'm like, why? And they go, because I love taking LSD. It's like, that's not really the right answer. It should be because I love working with patients with depression and trauma and PTSD. So I do think that if you are a good clinician and you've done all the training, to also have psychedelic experience is really good. It's very beneficial, but it's not as essential as being a good clinician.
And how would you say the role of the therapist differs in psychedelic assisted therapy compared to traditional talk therapy?
Well, it's not just how it compares to traditional talk therapy, but how it compares to treatment of mental disorders in general. Psychedelic therapy is the antithesis of our current medical model, which is taking drugs every single day to mask symptoms. So PTSD, for example, there's no single drug therapy for PTSD. We treat people symptomatically. So if they're depressed, we give them an antidepressant. If they can't sleep, we give them a hypnotic. If their mood goes up and down, we give them a mood stabilizer. If their hypervigilance becomes paranoid and psychotic, we give them an antipsychotic. And if they're constantly anxious, we'll give them a benzodiazepine. So there's 5 classes of totally different drugs, none of which are curing them. All of them are treating just the overlying symptoms. And you have to take them day in, day out for weeks, months, years, decades, just to mask your symptoms. Now, psychedelic therapy is completely the opposite of that. You only have to take the drug 2 or 3 or 4 times as part of a course to get better and then not be on drugs. So people focus on this as a drug therapy, and indeed it's using drugs, but it's more than anything, it's about the psychotherapy. We're using the drugs as adjuncts to create more effective, faster treatments with psychotherapy. And it's the psychotherapy that's important. Now, how does it differ from typical psychotherapy? Well, that's a good question. The drug sessions themselves are obviously very different from psychotherapy. Because they're very client-led, and often there's no talk therapy at all in the drug sessions. It's the opposite of CBT, cognitive behavioral therapy. You can't do like you do with CBT. You can't say, right, turn to page 14, we're going to do exercise 7B. You can't do that in a psychedelic drug-assisted session. We're very much encouraging the patient to be with the drug experience. They wear eye shades and headphones. They spend much of the session lying on the bed we call it being inside with the medicine, letting the medicine do the work. And then occasionally they'll take off the eye shades and the headphones and they'll sit up and they'll talk a bit, and then they'll go back inside a bit. And so during the drug assisted day, that full 6 to 8 hour day, it's very different from traditional talk therapy. Now, the non-drug sessions, which are really important and the majority of the course, then there's a variety of different psychological models that are used. Acceptance and commitment therapy is one model. Mindfulness-based therapies. You can also use CBT. So there's a range of different psychological models that are used as the supportive therapy around the drug sessions. But the important thing is it's not just the drug sessions. It's the other sessions as well that provide the scaffold, and particularly for integration of the sessions after the drug session.
Brilliantly put. And now I'd like to ask if we could talk a little bit more about the therapeutic potential of MDMA, and why is it that MDMA has such this predilection and is efficacious for addressing entities like trauma and PTSD? What is happening to make that particular medicine effective?
Right. Well, this is where my interest in developmental psychology as a child and adolescent psychiatrist really comes in. So I'll start with a bit of a lesson on the fundamental basics of human personality development. And this comes down to what we call the attachment relationship. Now, attachment, psychiatrists, child psychiatrists bang on about two things more than anything else. One is boundaries and the other is attachment. We love attachment. Attachment is this wonderful, beautiful, reciprocal dance that goes on between a pre-verbal infant and their primary caregiver. It's a wonderful relationship in which, in a pre-verbal, very young state, you develop a psychological understanding of yourself and your relationships and your world around you. What is love? What is trust? What is friendship? What is a brother? What is a sister? What is a mother and a father? Is it okay to get angry? Is it okay to lie? Is it okay to cheat and steal or drop litter? We learn these things when we're like that tall, and we keep them for our whole lives. So they become this kind of blueprint of our psychological functioning, those very early years. Now, that's great if you are cared for and loved and cuddled and played with and praised and told that you're beautiful and smart and clever and you're going to do well and you're going to be, you're going to achieve in life and people are to be trusted. But if you've had an experience of early childhood in which you've been frightened and scared and humiliated and abused or rejected and abandoned and neglected, then you build up a very negative picture about yourself and the world. I'm unloved, I'm unlovable, I'm useless, I'm a failure, people aren't to be trusted, the world is dangerous. And these become very fixed narratives within your child brain, and you carry them all through your life. Now, and forgive me, it's a very long-winded answer to your question. This becomes this blueprint, and it comes out later in life. Now, it can come out in any diagnosis. And one of the things I've talked about a lot recently in my talks is how psychedelics are dismantling what we know about categorical diagnoses. If you neglect or abuse a child, they will get something. It could be depression, could be an eating disorder, could be PTSD, could be anxiety, could be addictions. They're going to get something because of this disordered attachment relationship. And whatever the diagnosis is somewhat irrelevant in a way. The most important thing is that trauma underpins all of these diagnoses. So one of the problems with psychiatry is that our outcomes are so poor. You know, PTSD has a 60% treatment resistance. Addictions have a 90% treatment resistance. 90% of people post-detox, whether it's alcohol or opiates, will be relapsing within 12 months, 90%. That's appalling. I can't think of any other branches of medicine that would accept those kinds of outcomes. Yet we've become very used to this in psychiatry. So the problem being that these disorders come out of this disordered attachment, which is this very rigid narrative set that comes from those early experiences. What psychedelics, and particularly MDMA, do is they disrupt that. They give you this opportunity of neuroflexibility and neuroplasticity, and a therapeutic window is opened for a few brief privileged hours. And if we then hit them at that point with focused, bespoke psychotherapy, you can actually tackle these rigid narratives. Am I useless? Am I a failure? Maybe that's not right. Maybe there's another way of looking at it. And I haven't come across any other technologies within psychiatry that does this as effectively as MDMA, trauma-focused psychotherapy. So it really is the most exciting novel technology that we've had in psychiatry for 100 years.
Wow. Do you find that that potential benefit that is garnered through these sessions is sustainable, or do you find that patients may often need another session, whether it be 6 months or a year later? And what can patients do to really enhance that sustainability?
Yeah, that's a really good question. And again, it's one that comes up a lot. And it's one we need to be very careful of in the psychedelic community, in the way in which we discuss these medicines. They are not magic wands, okay? They are not gonna, I think sometimes there's too much emphasis placed on psychedelics having this life-changing, transformative experience. And we hear about people taking ayahuasca and then in one session coming back and their whole life has changed. That's pretty rare that happens. They're not magic ones. They do require work. I think of psychedelic therapy as, rather than delivering a cure, it delivers a toolbox. It provides you with the resources as to how you need to now go and live your life. And psychedelics really are the starting point. It's the springboard from which you then make lifestyle change. So I think we need to make sure we're not delivering. We have to manage expectations. Some people do have one session with a psychedelic drug and they say, wow, my entire life has changed. Most people don't. Most people say that was really profound. I need to work on this, that, and the other. So this concept of integration that can go on for weeks, months, years after psychedelics is really, really important. Now, should we repeat the course? Yes, why not, would be the answer I give. And again, there's sort of the eyes of the critics on all over the world are looking at psychedelics with a sort of, if it doesn't work first time miraculously, then it's useless. But why should it be that? Why we should be a level playing field, as it is with other parts of medicine. If you treat someone for leukemia and it doesn't work, you do it again. So I don't think we should be focusing on psychedelics as it has to work first time brilliantly in everyone. Why not repeat it? And I think, like you said, you could maybe repeat it 6 months later, 12 months later. What we don't want to do is see psychedelic therapy becoming a regular maintenance therapy. The thing that interests me about psychedelic therapies is it's getting away from that constant daily taking drugs. It's using it in a short, intensive, focused piece of psychotherapeutic work to then make lifestyle changes and continue to grow. But repeating the course 6 months, 12 months later, yeah, why not? I think that is going to probably be what happens.
Got it. And before we transition and discuss other psychedelics, I am hopeful that you can explain perhaps the risks and potential adverse effects of MDMA use.
Yeah, well, I don't want to say MDMA is very, very safe, but it is very, very safe. Now, we don't use words like safe and dangerous in medicine, actually. The question, when we talk about risks and benefits, the question you say with any medical intervention is this treatment going to benefit this patient at this point in terms that will outweigh the potential risks of using this treatment? So it's what we call a risk-benefit analysis. And that risk-benefit analysis is what we do in medicine. We don't use words like safe and dangerous. Are knives safe? Well, it's a stupid question. I mean, they could be. Are cars dangerous? Well, they can also be safe. So, similarly in medical interventions, we don't say safe or dangerous. We say, does this satisfy the risk-benefit analysis? And this goes for all interventions. So like a sticking plaster, sticking plasters, what are the risks? Well, they hurt when you pull them off. But the benefits, they stop the flow of venous blood and keep the wound clean. So generally, they satisfy the benefit over risk. Cancer chemotherapy, what are the risks? It destroys your entire immune system, all your hair falls out, and you could die. But what are the benefits? It can treat your cancer and get you better, and you can recover. And so again, all psychiatric medical interventions of any kind have this risk-benefit analysis. Now, when you look at that with MDMA, what are the risks? Well, it transiently rises your blood pressure and your temperature and your heart rate, which then come down after 6 hours. That's one of the risks, but that's something we can monitor. The old idea of neurotoxicity is pretty old now. Back in the early 90s, we were scared with all these pictures of holes in the brain and cognitive deficits. And we were told in the early 90s that there would be an epidemic of depression and dementia. Now, that just hasn't happened. We've had 35 years of heavy ecstasy use in this country, in the UK. 750,000 doses every weekend of ecstasy have been consumed, 750,000 doses in the UK every weekend for 35 years. And the rates of morbidity or mortality are staggeringly low. They are not zero, because nothing is zero, but they are very, very low compared to the epidemiology of use. So we know if MDMA was going to be a significantly harmful drug for society, we would know about it by now. When new drugs come on the scene, like, do you remember MCAT, I don't know what you call it in the States, methadone, it says cathinone, that came out in like late 2007. Within 6 months, we were seeing wards and clinics filling up with MCAT casualties. So you learn pretty quickly when a new drug comes on the scene. Spice, synthetic cannabinoids. You learn pretty quickly in drug services when a drug is going to be a public health problem. We've had MDMA for 35 years. It just is not a public health problem, even though people do take it in large amounts. So, and this is in the recreational, non-clinical context, where people are taking, 10 pills a night together with alcohol and cocaine and all sorts of things. It's still very, very low toxicity, MDMA. What we do know about MDMA is the few deaths that do occur every year get onto the front page of the tabloid newspapers, which puts out this idea that MDMA is somehow very harmful. It just isn't. We would know about it by now if it was. In terms of addictive qualities, very low. Again, it's not on the radar for addiction services, MDMA. You don't get drug-seeking behavior with MDMA. No one breaks into your house to steal your TV to get their next ecstasy fix. It just doesn't happen. Similarly, magic mushrooms. So we have to keep an eye on these things. But these are all things that can be very easily managed in a clinical context with screened patients who are monitored and cared for throughout. So it's a very, very low-risk drug, but it does carry some risks, as does everything, including cars, knives, and love.
Thank you for that comprehensive reply. Let's banter a bit about another therapeutic that you have some clinical experience with, and that is ketamine. What is the mechanism of action of ketamine, and how does it differ from other psychoactive substances?
So ketamine is unique in that it is the only licensed medical drug that is a psychedelic or has some psychedelic type effects. All the others are research chemicals, but ketamine already exists as a medicine with a capital M, as an anesthetic. And it's been around since the early 1970s as an anesthetic. It's a very effective, safe, short-acting anesthetic. It's indeed the anesthetic of choice in children and the elderly because it's so safe. It doesn't repress breathing, and it's very effective in it. It causes this strong dissociative effect that allows you to carry out small surgical procedures on children or the elderly in ER departments or surgical departments, and it's been used since the 70s. Well, interesting thing about ketamine, it sometimes gets labeled as a horse tranquilizer. It's so weird. I hate that expression. There are many, many drugs in veterinary science that are also used in humans. My cat got given morphine. My dog got given penicillin. You don't say, oh, penicillin, that dog antibiotic, or morphine, that cat analgesic. So why do we say ketamine, that horse tranquilizer? It's weird that that narrative has been allowed to persist. So it's used as an anesthetic. Now, ketamine is what we call a dissociative anesthetic. It typically produces a sort of outer body type dissociative experience. You feel disconnected from your sense of self. So you can see how this works as an anesthetic. It's almost as if you can look down on yourself, sort of in having this surgical procedure, go, oh, look at that person having that surgical procedure. That's interesting. But you're detached from it. So you can see how this can then be applied to psychiatric disorders and trauma, because it allows you to step outside of your normal frame of reference and look down on yourself in a judicious way in which you can explore your thoughts and feelings and recalibrate your relationship with yourself and particularly your body in a way that is very difficult to do in normal psychotherapy. Now, in terms of how it works, ketamine works by a receptor called the NMDA receptor, not to be confused with MDMA, completely different words. It's linked to the glutamate receptors. And what ketamine does quite remarkably is it actually produces protein synthesis, which results in new growth of neural tissue, dendritic tissue. Dendrites are the connections between neurons that communicate with neurons. If you take a slice of nerve tissue in a Petri dish, soak it in ketamine solution and look at it with a time-lapse photography, you can actually see these budding neurons growing, dendrites growing as you watch. And that process takes place within about 2 hours of taking ketamine. It can last for about 7 to 10 days. And so again, that's opening this window of opportunity. The ketamine acts as a primer, if you like, that creates this neuroplastic, much more connected, highly neural networked brain. and then you hit them with the focused psychotherapy in that window of opportunity. And that translates psychologically into new ways of thinking, new ideas, new novel approaches to things that you were previously stuck and very rigid about. So it's pretty similar to MDMA or indeed psilocybin. They all have this same effect of opening this window of opportunity.
Very interesting. Do you think that ketamine has any certain predilection for certain diagnoses over others? We're starting to see the science declare itself where perhaps psilocybin can be effective at treating cluster headaches. We've talked about MDMA, particularly for PTSD. Do you think that ketamine has some diagnoses that it's maybe the preferred modality?
I love this question. My feeling is that give us another 5 to 10 to 15 years in psychedelic research, and we're going to find that all of these drugs work for all psychiatric diagnoses. I think that the pigeonholing of certain compounds into different indications is an artifact of limited research. Every month, a new paper comes out. Every month I see a new paper saying, oh, apparently psilocybin works for anorexia nervosa. Oh, apparently ketamine works for personality disorder. Oh, apparently MDMA works for alcoholism. When is the penny going to drop? These all work for everything. They are non-specific adjuncts to psychotherapy. So if you take any psychiatric indication, depression, anxiety, PTSD, eating disorders, addictions, that currently is treated with psychotherapy, which is all of them, I would argue that they would all be even better treated with psychedelic therapy with any compound. So in answer to your question, if we look at the development of ketamine over the last 15 years, it's come to the fore as a rapid-acting antidepressant, and it's used a lot to treat treatment-resistant depression. Interesting the way this came about, it was through an anesthetist, and my anesthetists have gone up in my estimation hugely in hearing about this, because they don't normally pay a lot of attention to psychiatric issues. But there was this interested anesthetist 15, 20 years ago who noticed after giving patients ketamine anesthesia, his depressed patients were less depressed for a week afterwards. I'm amazed that anesthetists even bother looking at these parameters, but this guy did. And so it was discovered that this anesthetic that had been used for the last 30, 40 years actually works as an antidepressant. And what we saw was springing up, particularly in the States and Canada, huge hundreds of probably over 1,000 ketamine clinics using ketamine infusions as a rapid acting antidepressant. Now, that's without any psychotherapy. So even if you give no psychotherapy, you just go in, you get an infusion, intravenous infusion of ketamine, it's going to raise your mood for a few days or maybe a week or possibly 2 weeks after each infusion. But then you have to go back and have it done again. So it's a good antidepressant. It's a rapid acting antidepressant. It saves lives in that way, but it becomes a maintenance therapy. Now, what we did at Awaken, because I was already trained with MDMA and psilocybin therapy, we decided to use ketamine as an adjunct to psychotherapy. We weren't just going to give you a shot of ketamine and send you on your way. We were going to use the ketamine in a course of psychotherapy. And that broadened the indications beyond just depression. So we were able to use ketamine-assisted psychedelic psychotherapy to treat depression, anxiety, eating disorders, PTSD, and addictions. So I think that it's the combination with the psychotherapy that makes the compound more effective and also broadens the scope of possible psychiatric indications. So I think that's why we're going to be in 10 or 15 years. We're going to have MDMA, psilocybin, DMT, ketamine, 5-MeO DMT, all these drugs available. And any of them can treat whatever mental disorder you have before you. And what we're going to have is this patient choice position, whereby maybe in the first 4 to 6 weeks, you would try each of those different compounds and see which one you tolerate and which one you want to move forward with for your therapy. So in answer to your question, Burton, up till now, ketamine has largely been focused at depression, but I think that's going to broaden in coming years.
Thank you for that. Let's talk a little bit about logistics and systems of care. As you know, in a research setting, it may be feasible to offer psychedelics in a controlled environment. Currently, a lot of the models for ketamine, at least in the United States, are a fee-for-service after demonstrating that a patient has been refractory to the conventional treatment paradigm. How are we able to implement psychedelic assisted therapy when often the therapist and sometimes even two therapists at the bedside are needed for beyond the conventional hour time slot?
Really, really good question. Well, I'm very much a supporter of the National Health Service and public healthcare systems, and very much a socialist in that respect. I did not go into this field in order to just treat rich hippies. We need to develop these psychedelic medicines as free public healthcare for everyone. And we need to push regulatory authorities to move in that direction. It makes absolute sense to do it that way. Psychedelics work. They are safe and they are efficacious in combination with psychotherapy. It would be absurd to not use these as mainstay first-line treatments for these mental disorders for which they work. Now, like you said, it's an expensive, intensive piece of work. You know, 1 or 2 therapists for multiple sessions over 12 to 20 weeks. That's a big piece of work. That's a lot of cash. That's a lot of patient time. It's a lot of drug time. It's pharmacy time. It's therapist time. It's room hire. It's all of those things. That's a big piece of work. But what I often say in my talks is it makes economic sense to do it properly and to get the patient better. There is nothing more expensive than the untreated psychiatric patient. They cost millions over a lifetime. They need new legs, new livers. They don't work. They want disability benefits. They offend and go to prison. They have their children taken away from them by the courts. They are very, very expensive to suboptimally treat psychiatric patients. And we are cutting corners, and it's false economy to not do it properly at the beginning of their disorder and their career in psychiatry. We wouldn't do that with orthopedics. If you broke your leg, you had a fractured femur, you wouldn't say, oh, I'm not paying 15 grand to have that mended. I'm just going to hobble around on a broken leg and take painkillers for the rest of my life. You wouldn't say that. You'd say, all right, it's 15 grand, but God, I've got to get my broken bone mended. I'm not going to, what's the alternative? We should have that same approach with psychedelics. Yes, it's expensive. Yes, it's intensive. Yes, it's a big piece of work. But if you can provide that therapy for people in their early 20s when they first come into services, and it's curative, and there's a word we don't use very often in psychiatry, and they get better and they get back to functioning, that is 15 grand well spent, So it's expensive to deliver good psychiatry, but this isn't even just particular to psychedelics. This is just a perennial problem in psychiatry in general. We like sort of quick, cheap cures. How much is a month of Prozac? Probably about £2 for a month of Prozac. Is peanuts, but it doesn't work effectively in enough people. Too many people are non-responders, and then you have a lifetime of psychiatric care, which costs the state and the public purse millions. So we need to find mechanisms within public healthcare systems to provide free public healthcare with psychedelics early on in a person's psychiatric career, so they don't become lifelong unremitting patients, because it's the right moral and ethical and clinical thing to do, but it's also the right financial thing to do for the sake of public health services.
Brilliantly put. Well said. I would like to ask you what you say to those in the field who are trying to take the trip out of psychedelics, or another way of putting it would be, there is this group or a school of thought that wants to remove the mind-altering component to psychedelics, positing that perhaps there is some sort of anti-inflammatory or change happening at the cellular level, but there is this push. And what is your counter to that way of thinking?
So I have no problem with this sort of research at all. I think this is clever, focused, creative pharmacology. Why not do this? Now, I would have real problems if by creating a non-psychedelic analog of LSD meant suddenly LSD was going to disappear and we wouldn't have it. We're always going to have LSD. We're always going to have psilocybin, MDMA, ketamine. If you want a trip, they're always going to be there. But if we can, through clever creative pharmacology, also come up with new analogs of these molecules, that still work, but in some other mechanism, then this just increases accessibility. So I don't understand why people are getting so hot under the collar about this in the psychedelic community. No one's taking away your LSD or your psilocybin. It's both and, not either or. So, if we find that some wonderful new version of LSD that doesn't trip, but treats your knee pain, great. That all makes it accessible to people with knee pain that don't want to trip. So what's wrong with that? So I don't understand why people have a problem with this. It's not like we're going to lose the tripping. It's just we're going to have the tripping plus non-trip versions for those people who want it. And an interesting point about this is, Alexander Shulgin, amazing chemist, highly respected throughout the psychedelic community for the lovely guy and a lovely chemist, great chemist. What did he do for his entire life but tweak psychedelic chemicals in all sorts of ways? He loved phosphorylating this, dephosphorylating that, methylating this, ethylating that. He loved it when he came up with a compound that didn't have psychedelic effects. He was interested in all of them. He was a good creative chemist, and he's held aloft as this great pioneer of psychedelics. He was a firm supporter in analogs that have all sorts of effects. So let's not fear this. Let's not fear tweaking psychedelics in whatever way to create more options that might work for more people. As I said, I would be worried if it meant we're going to lose the old ones, but there will always be mushrooms growing in Wales.
And how do you think about the paradigm of microdosing compared to a lot of what your research has been utilizing larger doses? There's such variability with microdosing, and how does your brain wrap around that phenomenon?
Oh, microdosing. Well, it's a difficult one, microdosing. One of the reasons I'm not a massive fan of microdosing is because I don't like the concept of daily maintenance drugs, whether it's MDMA, psilocybin, ketamine, or Prozac. I like psychedelic therapy at a high threshold dose because you only have to do it 2 or 3 times alongside a course of psychotherapy, and then you're drug free. So microdosing has always sat a bit uncomfortably with me because you're still taking a drug every day or 4 days a week. You're still stuck in a maintenance drug program. I like the concept of intensive, upfront, high-dose psychedelic therapy to then not have to sit on any drug, whether it's a psychedelic or an antidepressant. So that's one reason why I'm not a big fan of microdosing. The other is the science there's certainly a strong suggestion in the science that it's a placebo or expectancy effect, and it's not necessarily an active drug effect, although I know the jury's out on that. The other reason I've come into problems with microdosing is so often people are not microdosing, they're threshold dosing. People come up to me at conferences, hey Ben, I'm on a wicked microdose buzz today. If you're on a microdose buzz, you're not microdosing, you are tripping. And if you take psychedelics every day at a threshold dose, you're going to go loopy. So I think that's a problem. I think people microdose too high. When you're starting microdosing, you've got to start really, really low, go up very, very slowly. And as soon as you start to feel something at all, drop down to 2 levels below where you didn't feel anything. That's your sweet spot. So I've seen too many people really develop problems because they thought they're microdosing and they're ending up taking LSD 5 times a week for months. It's problematic. So I think for me, the jury's out on microdosing. Having said that, everybody who does it says it's great. But again, is this a placebo expectancy effect? Everyone that does crystal healing and horoscopes think they're great. It doesn't mean there's an active effect. So yeah, let's see where this goes. But I'm much more flying the flag for proper high dose, threshold dose psychedelic experiences with guided psychotherapy in order to be drug free.
And I do recognize and respect that your area of expertise is psychiatry and pharmacology, but being as immersed in this space as you are, I'm wondering if you could share your take on where the science is heading as we see it, with psychedelics potentially being invoked for neurodegenerative diseases, traumatic brain injury, and other organic diseases of the neuronal tissue.
Yeah, well, I think as we said, this concept of neuroflexibility and neuroplasticity is really interesting. And it would make sense, therefore, if they are resulting in transient increased network connectivity, neurodegenerative disorders, Alzheimer's disease, multiple sclerosis, spinal injury, anything that results in a paucity of neural networks because you've lost brain tissue for whatever reason. Psychedelics, if they can increase the network connectivity of existing brain tissue, then you can imagine how this can be beneficial. It's an area that deserves so much research. I took part in an LSD experiment with 10 years ago in the elderly and cognitive functioning in the elderly. And the results have never been published, but I do think this is going to be the next big thing in psychedelics. The question is, how often would you need to take them, and at what age would you need to start in your life to increase this neural network activity that's going to be neuroprotective against degenerative disorders like Alzheimer's? And I think the jury's still out. But we do know that Albert Hofmann, who took LSD regularly, lived to 102. So there's something to be said for, it's like taking your brain down the gym. It's giving your brain a bit of a workout. You don't, but unlike the gym, you don't want to do it too often. But if you do it in a focused and measured way, a few times a year, classic psychedelics or MDMA, I do think this is good for your brain. It's not toxic, and if it's done in the right way, it's a wonderful platform for personal growth and development, and could even be neuroprotective down the line. But I can't say that statement with any evidence. But I think this is an area of research that deserves a lot more limelight.
That's fascinating. And I recognize and understand you are one of the featured speakers coming up at the MAPS conference that's going to be held in Denver next month. Would you be willing to share a little bit of a preview of what you'll be discussing and presenting?
Yeah, so I'm going to do a talk. I think all the talks are like 15 minutes. So they want this kind of real TED talk, sort of bam, 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 no slides, you know. So I'm not going to use a slide deck. I'm going to stroll around the stage like a silverback gorilla and just talk for 15 minutes. I think I'm going to talk about psychedelics as disruptors and this capacity to disrupt the rigidity of trauma, which is due to child abuse. So a little bit like what we talked about at the beginning. How they're also disrupting the concept of categorical diagnoses, the idea of depression, anxiety, PTSD, eating disorders. I see these things as all one thing. They're all trauma-based disorders. And psychedelics are disrupting that. They're disrupting how we look at healthcare, how we fund healthcare, how we invest in healthcare and biotech. Everything's focused around this drug for this disorder. Psychedelics blow that out the window. You know, if it's like multiple drugs could work for multiple disorders, how do investors get their heads around that? How does the psychiatric industry, how does hospitals, how do insurance groups get their heads around funding that? We need whole new paradigms on how we put psychedelics into public healthcare. But what we do know is that they have great benefits. They are safe and they are efficacious. And we need to find a way to bring this into public healthcare, not only because it's going to help this huge population of patients, but it's going to rescue the financial state of public healthcare, which has become this bottomless pit of money that's required. You know, good psychiatry is about holistic psychiatry. It's not a biological treatment. It's a biological, psychological, and social treatment. We have to focus on the holistic aspects of these drugs. We have to use these psychedelics to change our lifestyles, to spend more time carrying out leisure activities, being with our friends and our families and our children, increasing connectivity, increasing community cohesiveness, and growing and developing as communities. And the psychedelics have this ability to do this, as we know from ceremonial use. We need to find ways to envelop them into the modern Western biological public healthcare systems that's going to benefit us all into the future.
I agree wholeheartedly. And as we approach the top of the hour, I would like to invite you to perhaps share any closing remarks, or maybe even predict how you see the field expanding over the next several years. What are your hopes, potential setbacks that you envision, and just an overall thoughts as we part?
It's very difficult to know because it's moved so rapidly. You know, for the first 10, 15 years I was working in this field, it was very much academics in university departments carrying out small pilot studies with small grants from here, this place and that. And suddenly in the last 3 years, it's exploded. And there's been a huge amount of cash come pouring in, ironically, from Canadian cannabis entrepreneurs who then turned their attention to psychedelics. Suddenly there was billions of dollars floating around 3 years ago. Loads of investments were made, loads of startups happened, many of which have now plummeted. And the investment situation is all looking a bit fragile. So God knows what it's going to look like in 3 years. What we need to do is really work to get these into public healthcare. I think it's hard to predict what the future is going to be, but I'm optimistic that the science works, the clinical care works. So we're going to find a way to bring these into modern healthcare systems. We need to keep a keen eye on indigenous uses. We can learn a lot from non-Western uses and ceremonial uses, but we need to find a way to convert that into Western uses. You know, we can't fly everyone out to Peru to take ayahuasca in the jungle. It's just not going to happen in terms of our own public healthcare systems in Europe and UK and America. We need to find a way to bring it into our modern Western world, learning the best we can from those indigenous cultures, holding on to that magic and the curiosity and the mystical spiritual aspects of psychedelics, but needs to be translated into modern healthcare systems, or it's going to fail. So we need to find a way to translate that message. And above all, we need to tackle the drug laws that are impeding research, because they, as you said at the beginning, they create this stigma, which is really poor for patients because it reduces their accessibility to these otherwise safe and efficacious treatments that they deserve.
Fantastic. And with that, I would like to extend sincere gratitude to you, Dr. Ben Sessa, for your time today and your expertise. I would also like to thank Psychedelics Anonymous for serving as the sponsor and for providing this platform for us to talk. And lastly, thank you to all of those who tuned in live and who are listening in to the recording. Much appreciated.
Thank you very much. I've enjoyed it immensely, and I'm off to meet my buddies down the pub now in Oxford.